Okay, Gaynor-Hart view of the carpal tunnel.
How's that look?
I'm not sure. Where's your central ray located?
Here.
Okay, an uncooperative patient is not pulling their fingers back for us. Okay, that's a little better. There you go. So our central ray is supposed to be located about an inch below that third MCP. Righto? Okay, is that for Riz as far back as you can pull your finger? I mean, don't, I'm not trying to get you to hurt yourself. Okay, that's a little bit better, I think. Because we're not going to have a good view of those metacarpals. Those things are going to be all superimposed and appearing like end on. But we do want to get a good view. Basically what this is just like a tangential shot down through the palm and through that carpal canal. It's not super pretty, but if the doctor wants to see how those carpal bones are oriented relative to one another, sometimes this shot can help.
Okay. And then the next one, Stetcher.
Okay, now it's time for Stetchers. Stetchers.
This mask hurts my fingers.
Don't they all?
Do we have any of those doctor ones here?
A doctor mask?
Like the one you have?
Oh yeah, we do.
Because this one's hurting my ears.
Complain, complain. All right, we'll hook you up with a fresh mask in just a matter of moments. Okay, now the book says we're supposed to be 2 centimeters distal and 2 centimeters, I guess, medial to the styloid process of the radius. But, okay, to me it's easier just to think a 1/2 inch and a 1/2 inch.
Is this one
Okay.
with the ulnar deviation?
This is going to have ulnar deviation if the patient can tolerate it. And it turns out our patient can tolerate a lot of positioning and smack talk.
That's good.
I know, right? That's real good. In this lab, that's a big advantage.
And you center, where do you center again?
Okay, very good. Okay, try to find the styloid process of the radius, which is right about where your fingers are. And then you're going to go about a 1/2 inch, or I think actually it's 3/4, but you know, around a 1/2 inch distal and then a 1/2 inch medial. And that should put you right on top of the scaphoid.
Do you have to collimate anymore? Is that good collimation?
Yeah, well, okay, you can collimate pretty tight for this. You don't necessarily have to include all the carpal bones. But at the same time, you don't want to cone off your marker. So yeah, you could collimate down to like a 4x4 square.
Does your marker usually go laterally?
Marker goes lateral unless there's some reason why you can't do it.
Do it lateral to the bottom?
For a lot of things, it's towards the bottom. But there again, it depends on the anatomy you're trying to demonstrate. You want your marker to be, now in this it's easy because we have light outside the patient's body, so we can just put our marker there, no problem. But when you're doing something like an abdomen, you know your patient's taking up the whole dang screen, right? So then you know your marker is going to be in anatomy. So we just want to make sure that it's somewhere that, you know, even though it might be overlaying, it won't mess up the doctor's diagnosis. So like you were saying, put your marker, like for an abdomen, you're going to put your marker low and, you know, like to the edge of the film. And that way you're pretty sure, because we don't really care if it's in the greater trochanter, you know, as long as the doctor can see all of the patient's bowel tissue. But for extremities, it's pretty easy. All right, next up is going to be PA axial. All right, Ms. Abby, what kind of an angle do we need on this tube?
I got 13.
Okay, 13 degrees. That's between 10 and 15. Do we need any deviation on this one?
Yeah.
Why, yes, we do. What kind of deviation?
Ulnar deviation.
Ulnar deviation. All right, thank you, patient.
Second.
That's good. I think that's fabulous. And now, last but not least,
The radial deviation.
radial deviation. This is going to deviate towards the radius. Okay, and now our centering point has changed. We're no longer going to be aiming specifically for the scaphoid. We're going to have our central ray approximately
Mid-carpal.
mid-carpal. Exactly, very good. All right, good job. And, okay, and it just so happens that Ms. Abby needs exactly, her forearm is hurting for certain. Okay, so how are we going to position for a forearm x-ray? Okay, well, this is a self-positioning patient. All right, let's just give her the keys to the x-ray room and tell her to, we'll see you in a little while. Take your own x-rays. Oh, there's another way we could make money. We could set up, okay, you know how they have those photo booths that you go in and you put in like some money and then it just like starts snapping pictures and you can like pose and everything? We could do the same thing with x-ray.
Yeah.
We could just say, you know, like, you know, you swipe your credit card and then it's just like an x-ray machine and you could just like stick your hand in there.
Yeah,
And
I would do it.
this has potential, I'm telling you. Okay, where are we going to be aiming for this x-ray?
I don't remember.
Okay, well in that case, let me jog your memory. The midpoint of the forearm, mid-shaft of the forearm is where a central ray is going to go. And we want to make sure we include all the wrist and all the elbow. So can we get all the wrist and elbow on this 10 by 12 image receptor? Why, yes, we can. Okay, now what if I gave Ms. Abby some vitamins and all of a sudden she grew and so her arm was like 7 more inches long?
Can you do it like that?
Well, okay, that's a possibility. You could totally shoot it diagonally. But what I was kind of driving at was reach over and get a 14 by 17 image receptor. Just switch to a bigger image receptor. Now, if you're using DR, it's not an issue. You're just going to be coning down to the size of the part. You know, you got plenty of real estate there to work with. But definitely you got to include all the wrist and all the elbow. And it needs to be in a nice, straight AP orientation with the epicondyles approximately parallel to the image receptor. All right, so Miss Kristen, do your thing. Position that patient. Okay, that looks pretty good. We're just determined to mark this thing medially. So I guess that's what we're going to go with.
I know, I keep going.
I do too. You're not alone. Okay, that looked pretty good. Now we're going to do the next image, which is lateral forearm. Okay, now for lateral forearm, can I just get her to, you know, as long as her arm is straight out like that, can we just turn it up like this and call it a day? Yeah, well, we might, but that's not a very good idea. There you go. We're gonna bend her elbow. All right. That tube, oh, I see what it is. Your tube's in detent to the table. That's the reason it's being so such a problem with moving. We've got it stuck in detent. Okay, now, it just so happens that since we're having such a problem moving the tube, let us do something like this. And just kind of float the patient around a little bit. Once again, we're including, and you can open up your collimator a little bit lengthwise. We need to include the wrist and the elbow joint. Make sure they're in the light field and on the image receptor. And then we're going to ask Ms. Abby to do something additional for us. See how her humerus is kind of at an angle to the image receptor? That's going to mess up our joint space. You see what I'm talking about? Mm-hmm. Okay, so how can we get her arm more on a level with the table? Well, we could. Hang on, let me back up just a little bit. All right, bring that table on up.
As high as it goes?
Yeah.
Yep, that's all she wrote. Okay, so the table is as high as it goes. So what can we do with this patient? There you go. Okay, we're just gonna, okay, patient, can you slouch down for us? Okay, now our humerus is basically on plane. Cool, what do you think? All right, we got a thumbs up from the patient.
Does it matter that this is at an angle?
That's supposed to be at an angle. We want it to be, oh, do you mean it's not exactly at a 90-degree angle? Okay, well, it would be nice if we had more of a 90-degree angle, so we'll get our patient to shift over just a little bit. There you go. Okay, and it looks like the shadow of the patient's elbow is all on the image receptor, so that should work. This is actually one of my favorite. Like when I see forearm x-ray on a requisition, I'm like, yes, because it's just like, you know, 1, 2, back to your room. It's pretty easy. Okay, very good. Okay, what's the examination we're doing here?
An AP forearm.
All right, cool. Very good. Okay, now squeeze on her epicondyles and make sure that they're going to. Okay, so do you think her elbow joint's going to be included on this image?
Maybe.
Okay.
Should I put more of that?
I'm thinking. There you go. Push it down like that, because I think you've got plenty of wrist anatomy on there.
Maybe I go up now. Like that?
Yeah. You can either move your image receptor and your, now are you centered to the IR? It looks pretty good.
Move it a little bit.
It's like that tube is stuck in concrete.
Is
It
that
doesn't
better?
want to budge. Yeah, I think so.
So you gotta make sure your elbow's in there.
Mm-hmm. You want to make sure you include that elbow joint.
Nice. Okay. And
Now, okay, what if we take this image and we've clipped off the elbow joint? Oops. Well, do we redo the whole thing, or can we can just do a supplemental AP elbow, right?
yeah, should you just move it down and calm it?
Uh-huh.
Okay.
Exactly.
Now lateral.
And next. All right, now for our next trick. There you go. Move that patient. Don't let them slack off. All right, now we just need marker, shield, and shoot.
Right arm. Actually, I could do a little more. Should I calm it a little more, like the
Side to side, yeah. You can come down the skin line side to side. But lengthwise, I would leave it open like you got it, because I can see that her elbow shadow is getting close to the edge of the receptor.
Is that where you put it?
I would put it, okay, look and see where's the widest area of light that you've got. Yeah, there you go. Just make sure your marker's not in the anatomy, but you want it in the light field, but not overlapping her skin, if you can avoid it. That looks good.
No. I guess that's all for forearm. Now we're on to elbow.
It is. Okay, during our commercial break, I gave the patient some growth hormone. Now her arm is really long. Not a problem though, because we have some bigger image receptors. The student is locked in one-to-one combat with the X-ray tube. Mano a mano. All right, what do you think? Have you got your patient's arm lined up with the image receptor? Is it basically straight?
Yeah, I think so.
Okay. Well, you've got everything on there to be sure. Okay, that looks pretty good. All right, now for our next image. Lateral aspect. Oh yeah, that's going to fit on there with room to spare. There you go. You want to open up, you don't want to clip off any of that olecranon. Oh, you're cutting it close. I mean, I'm all about some tight collimation. But we better just pray that our light field decollimator is dead on.
Is that good?
I don't know, what do you think? I think you need to open up side to side just a little more. There you go. That's better. Now I'm all up for tight collimation to a point. I don't want to run the risk of clipping something off and having to repeat it. You know what I mean?
Mm-hmm.
All right, very good. Forearm x-rays. All right, AP elbow, what's that going to look like? Yeah, just about like that. Now for an elbow x-ray, if we have 10 by 12 or 8 by 10 cassettes available, we can use those, right?
Yeah.
How much of each side should she include?
Think about 2 inches of humerus and about 2 inches of radius ulna. Maybe a little more. The main thing we're looking for here is the joint space. We want to see that elbow joint because what the doctor's looking for is fractures and dislocations. And sometimes there's just bruising, you know, because somebody will like hyperextend their elbow or twist it or something like that. And so the bone's intact, but there's a lot of soft tissue damage. All right, you can cone down a little side to side. Just make sure you don't clip off your marker. Cone down. My teacher used to say cone down to skin line. Okay, there you go. That'll work. Elbow x-ray. Goes right through the joint. Okay, what's the next elbow x-ray we're supposed to be doing?
Internal oblique.
Okay, cool. How do we do an internal oblique? Whoa! Okay, that's real oblique. Okay, all right, patient, get back in the AP position like you were. There you go. Okay, now then, ma'am, what I'd like for you to do is just, you don't have to move your arm, but I need you to just roll your hand so that it's palm down. There you go. Okay, can you hold that position for me?
I guess it is oblique when you just do this.
It is. This is going to produce an internal oblique. Now, the main thing we're looking for on the internal oblique, and this is rarely, hardly ever do I see a doctor order this, once in a blue moon. And what the doctor's looking for here is something in particular, which is called it's some kind of process.
Volcanoid?
The olecranon?
Yeah.
The coronoid process.
Coronoid.
The coronoid process of the ulna is what we're looking for. Because sometimes that'll have like a little fracture or an avulsion. It might even have like a chip of bone knocked out of it. And this will let the doctor see if there's any problem there.
Okay, and then external is like.
Okay, external oblique is, there you go.
Don't you like?
That's actually really good. Some patients can do this and some patients can't.
Tell it. Why does my arm look crooked? Doesn't it look
Because you got it in an external oblique
Doesn't it look weird?
rotation. Yes, it does. But everybody's arm looks like that when it's rolled way external. Now on the external oblique, we're looking for something in particular. We want to see I know it was right there on the tip of my tongue. It's got something to do with the radial head. Oh, that's right. We want to see the radial head free of superimposition. And hopefully with an open joint space between the radial head and the capitulum.
Okay.
Very good. Okay, so that's how that goes.
And then the lateral.
Now lateral elbow.
This light really brings out the arm hair.
You're right, it does.
Yeah, very arms.
All right, that looks very good. Now, where are we supposed to be centered for this thing?
Like mid-elbow joint?
Yes, we're supposed to be right
Is
through
there a
the
little
elbow
pit in
joint.
there or something?
So, yeah, you're gonna feel those epicondyles, and then you're gonna go just a little bit distal to those. And that's gonna put you right through the elbow joint.
Okay.
Which makes sense. Whenever you look at an x-ray of the elbow, you'll see exactly where that joint space is located.
When you said
The high-tech tech.
so, there's two coils, and one you do this, and one's this.
And they're both this. One's a 45
Well,
towards and
yes.
45 away.
Exactly. Now the one that's the 45 away, we can practice that if we have time. I don't recall having ever done that like on a patient. But the other one, you know, the one that's towards the patient, I've done that a lot. And y'all will too. We eschew the idea of a correct image receptor size. We're just going to use the big plate for everything.
Gosh, how far do I have to go back?
I don't know, but you're about to whack me with this high voltage cable. Ow!
Okay, that was really far. Okay. And then she does this.
Yes, the hand is pronated for this image.
A nice 90. And then do you go in? Where's the center?
Okay, the central ray is going to, remember how a few minutes ago when we did the lateral, we found that epicondyle and then went a little bit distal to it? We're going to do the same stunt again, but except for, you see where your central ray is? Mm-hmm. It's a little low. I want you to raise your central ray somewhat so that it's more towards that, like bring it up so that we're going through that. Nope, other way. The Coyle method. Yeah, see, you want see where the humerus is right here? Okay, so you can see where her humerus is because it leads basically straight up towards her neck. So what you want to do is like locate the humerus and then go just a little bit distal to that because you want to be through this joint space right here. Okay, so you want to be just in front of that bone. Mm-hmm. Okay, all right, so take it in. Ready?
So, when you say distal, do you mean going down like this?
No, towards her hand.
Oh. So should it be over here?
Can you feel her?
I think this is her condyle.
Can you feel her epicondyles? Right there it is. It's that giant bone sticking out. Okay, so right there. Yeah, you're approximately correct. That's
so
good.
Up a lot more too.
Now that I'm over here, I think you're okay. See where her, you're just up above the elbow. I think you're fine.
So you go over and down?
Yes.
Okay.
What you said.
And then for the other one, do I do it all the way, like on this side, and then you aim in through here?
Yes, ma'am.
Where would you center at
Your centering is going to be the same kind of thing for both. Now, okay, for this one, for this coil, and it looks like we are basically 90 degrees. But for the other one, like for the coil that goes, I don't know, I call it the reverse coil because it's going in the reverse direction, then you're not going to have quite as much flexion. You're going to open out a little bit more so that you can see. The coronoid process, thank you. That was right on the tip of my tongue, I promise. We've only been talking about it all day long, so you can see where I'd forget.
The radial head.
Yes, we want to see the radial head without superimposition. Now it's going to be elongated as heck, but that's okay, you know, because if there's any, like if there's any damage there, then that'll actually enhance it. It'll make any, like a hairline crack or something, it'll stand out. And that's what the doctor wants to see.
For the practical, do you think she's going to give us one of the wrists, one forearm, and one elbow?
I don't know, but that's entirely possible. Because what Miss Berger has is like, she's got a bunch of cards. And it might be like a, I don't know, like a finger and a wrist and an elbow. Or it could be a forearm, an elbow, and thumb. You know, every card is different. And she's going to basically fan them out, you know, like a riverboat gambler. And she's going to say, pick a card, any card.
Is this before or after we get into the room?
After you get in the room.
Oh, so you can't practice out here?
You don't know what you're going to see. So that's why it behooves us to practice ahead of time. So that no matter what she throws at you, you're like, oh yeah, we did that. I know exactly how it sets up. And if you can picture it in your mind, then you can just say, okay, I need to have the tube angled, I need the patient to be straight, and I need to shoot through the elbow joint. Got it. Mm-hmm. You know? And so just kind of be thinking about in your mind how this thing's going to go before you actually start doing your thing. Mm-hmm. And you're going to be fine. You know? There's not going to be anything on there that you hadn't seen. All right, y'all are going to practice doing the radial head until you can do it blindfolded. You said you were at an orthopedic site, right?
No,
so you've
I
done
was
a
at ED North.
Okay.
Did you like it? No, not really.
I didn't really like mine either.
Very slow.
Okay, now is that patient's elbow at a 90-degree angle, or is she slacking on us? There you go, that's better. See how that central ray is going to be just like right in front of her humerus? Mm-hmm. All right, what do you think? Good stuff?
Yeah.
I think so. I think that looks about right. Okay, very good. Excellent work. Ta-da. Why, yes it would.
Do you see our in the crease?
Yes, that's exactly right. We're still aiming at the elbow joint, but this time, okay, for this shot, we're going to be getting the humerus. That's going to be demonstrated. And then for the next image, how are we going to do that? Now, we can't straighten the lady's arm out. It's going to have to be something like that. How can we get her in such a position?
Stand up. Right?
Get up, stand up.
Stand up.
I think that's a good idea.
Like that?
Yes, just like that. Okay, ma'am, there you go. Okay, so now we've got our central ray in the patient's elbow joint once again. Okay, so now we've got two images. One like this, one like this. Now, there's also a trauma external oblique, which I don't think is in the book. At least not in this book. But for the trauma external oblique, you're going to try to roll your patient external Okay, ma'am, can you roll? Oh my goodness, oh that hurts, oh. Oh, she's cured. She's able to straighten her arm out.
It's like this.
It's a miracle. There you go, that's better. Okay, but in reality, because a lot of times when people come in, if they've got like a for real injury to their elbow, they've got it cradled. You know, they're holding it like this. So for somebody that's holding their elbow like this, another thing you can do is you can basically just slit the image receptor between the patient's body and their elbow, and then shoot through for a lateral, and go ahead and get you a preliminary image and see if there really is a break there. Okay, if you shoot a preliminary x-ray and you see a broken bone, then you know, okay, I can't manipulate this person's elbow at all. But if you look and you see that there's not a broken bone, then you can ask them, you know, say, ma'am, you know, do you think you might be able to straighten your arm out a little bit? But we don't want to do that if we think it's going to, you know, wind up hurting them worse. But just get them to do whatever they can. And if they for real can't extend their elbow all the way, then you do that the double shot like we showed you. And what's the next thing? Was there another one of those?
It's a trauma external oblique that we did Coyle with it.
Okay, so we already did Coyle. Cool deal. That really is the most important one of those. The trauma AP thing. And sometimes there's something else called split the difference. So, like if Abby, okay, Abby, get in the position. Okay, so if she's like, instead of putting her humerus all the way down like this, what we might do is just, okay, ma'am, I'm going to get you to kind of, there you go, like that. Okay, so now I've got an angulation here and I've got an angulation here, but those are about even. So I'm just going to do that and shoot. Okay, and this is like adaptive radiography. Next year, your last semester of your senior year, we'll do a bunch of stuff like that. All right, cool, y'all. Thank you very much for your kind attention. I appreciate it, and thank you for participating in my videography, my video log of the X-ray lab.